Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening and welcome everyone. Thank you for joining us. My name is Osama Ziada and I love working at Haleon. More than 1,800 dentists have already registered and a lot more are still joining. Well, the webinar topic, as you know, is combating dentine hypersensitivity, and we have a very special guest tonight. There will be an opportunity for questions at the end of this webinar, so please submit them in the question chat box, which is on the right-hand side of the screen. I have the pleasure of being accompanied by an internationally regarded expert, Dr. Hamid Khalid Abdul-Hamid. Dr. Hamid boasts an unrivaled reputation as one of the world's leading clinicians in the field of dental aesthetics. His expertise has been rewarded with a host of industry awards and appointments, which include Chairman of the Arab Academy of Dental Aesthetics, Chairman of Saudi Medical Forum, KSA, and Director of the British Centers for Excellence in Dentistry, United Kingdom, and Regent for the International Academy of Dentofacial Aesthetic in USA. Dr. Hamid serves as dental advisor for the royal families in GCC, and he's an advisor for the main health and beauty magazines and TV stations in the Middle East. This year, he was awarded the International Dentist of the Year and Lifelong Achievement Award by Top Summit Institutes of California, USA. Ladies and gentlemen, Dr. Hamid Khalid Abdul-Hamid. The floor is yours, Doctor.
Thank you very much, Dr. Osama. Thank you very much for inviting me, and thank you very much for this kind introduction. And thank you very much for Haleon for your kind invitation. Ladies and gentlemen, good evening. This evening, we're going to talk, as Dr. Osama mentioned, we're going to talk about how to manage the dentine hypersensitivity. Now, dentine hypersensitivity, the prevalence, it's a very high in the world. According to different studies, it ranges from 30% to 70% among population. And before I start the slides, I would like to tell you a history on dental hypersensitivity. 2,005 years ago, BC, which means nearly 5,000 years ago, the Assyrian king in Assyria and in the Babylonian and the Mesopotamian civilization, he was suffering from severe, short, sharp pain in his mouth. And his doctor, which we found in the clay tablets in Babylon, he prescribed like a medical diagnosis. He said, "My lord, you suffer from pain from your teeth." And he prescribed some herbal medication to combat this short, sharp pain. And I believe this is the early beginning of diagnosis of dentine hypersensitivity. Now, this evening, we're going to talk about the following subject. I'm going to cover the following subject. First of all, we're going to talk about the etiology of dentine hypersensitivity, the contributing factors. Also, I'm going to talk about the pathophysiology, the pathology and the physiology behind this severe condition, and what is the treatment modalities and targets we are going to discuss this evening. Then I'm going to go through the GSK research on the innovation in the managing the dentine hypersensitivity, and also we're going to talk on the impact on the patient health. As you know, dentine hypersensitivity could be a very difficult condition to live with, and then we'll summarize at the end of this evening. Let's start with the definition. Well, all the textbooks, including the Oxford Dictionary, describe dentine hypersensitivity as a short, sharp pain arising from exposed dentine in response to a stimulus. Now, you need to have an exposed dentine in order to have this dentine hypersensitivity. And the stimulus could be either thermal, like hot and cold, or acidic, like drinking soft drink, or lemon juice, or vinegar, like salad with vinegars. And as you know, in the Arab world, we like to have our lemon and vinegar. Or it could be osmotic, or could be tactile, like brushing, or mechanical, like grinding. So this sharp pain, by definition, it has to be of non-pathological condition, so which cannot be ascribed from any form of dental defect of pathology. And we're going to go through this later, so it's by exclusion. Now, what are the causes of dentine hypersensitivity? Well, unfortunately, when you have exposed dentine, this condition of exposed dentine could be either by erosion, and erosion, as you know, is the acidic removal of dentine by acidic, which is non-bacterial acid. It could be either, in three reasons for this, could be either from diet, like, as I mentioned, acidic food, or fizzy drinks, Coca-Cola, or even the carbonated water. Do you know that all the soft drink, even the fizzy water or the carbonated water, the pH for this is only 2, between 2 and 2.5, while the vinegar has got also pH of 2 to 3. So when you drink a can of any cola, you are really drinking vinegar. That's why it's very important to advise your patient not to consume soft drinks. So we say the first one could be dietary. The second one could be internal, like esophageal and acid reflux, acid regurgitation. A lot of patients who have stress or irritable bowel syndrome or acidic, very high gastric content, normally because of stress. And unfortunately, 40 to 60% of the Arab population, they suffer some kind of stress, according to the Arab Association of Psychiatrists. Or the third causes of erosion, it might be caused from industrial, like, worker of factories where they use acid fume without using the mask or the preventative measure. This can also cause erosion. The second reason why patients lose their enamel and exposed dentine could be by abrasion. And abrasion, by definition, is the tooth wear caused by direct contact between teeth. So teeth-to-teeth contact, and mainly happen because of parafunctional habit, or what we call it bruxism or grinding. And unfortunately, again, nowadays, because since COVID and since the economic hardship in all the Arab countries at the moment, we have a very high prevalence of bruxism. I did some small observation in my clinic in Riyadh, and I discovered that 75% of patients which I saw in the year 2021, they all suffer from kind of parafunctional habit. And the third cause is the abrasion. Abrasion is tooth wear caused by object other than tooth that will remove the enamel and expose dentine. And this is like aggressive tooth brushing, some bad habit like pencil biting. In the old ages, I don't know whether still people, the pipe smoker, they keep biting on the pipe and they remove some of their enamel and they expose dentine. So this is really three main causes of tooth wear. So we have tooth wear sub-classified into three causes. The second main causes of dentine hypersensitivity is when you have receding gums or gingival recession. Now, gingival recession, unfortunately, could be caused either by bad periodontal health, with periodontal breakdown, where the gingiva would recede, and unfortunately, in the Arab world, according to the latest study, between 40 to 60% of the adults, they suffer from some kind of periodontal breakdown. Or The other reason could be an excessive use of force in brushing technique. If we use the wrong technique in brushing, in Eastman Dental Institute in London, which I had the privilege to work for 15 years, from senior house officer till become a consultant, we measure, and Professor Scully, God bless his soul, he discovered that in order to achieve the adequate pressure on brushing, it should not be exceed more than 32 grams, the weight. And this is, you could ask your patient to weigh on one of the food scale, to weigh the brush and see it's just holding the brush. Any excessive brushing could cause removal of dentine and exposure, gingival recession. And when the cementum exposed, unfortunately, the fusion between cementum and dentine, the cemento-enamel junction and the root, it's very weak. Once it's protected by the gingival fusion. Once the gingiva is receding, you immediately lose cementum and the dentine will be exposed. So you will get the second cause of dentine hypersensitivity, which is gingival recession. Now, as this is a beautiful slide to see that, you know, to achieve a good oral hygiene, which I mentioned is 32 grams of pressure. It has to be twice a day, 2 minutes every time. You have no very minimum risk of gingival recession. If you use excessive force, more than 32 grams, you will have over vigorous brushing technique will cause gingival recession and dentine hypersensitivity. If you don't look after your teeth, if your patient ignore their oral health, they don't brush their teeth, dental plaque will develop, periodontal breakdown, and will cause also gingival recession. So both spectrum will cause gingival recession. Now we mentioned the etiology of dentine hypersensitivity. Let's go and discuss the pathophysiology, pathology and physiology of behind the causes of this sharp, short pain of dentine hypersensitivity. Now, this slide shows beautifully that when you have a healthy tooth, you could see that enamel, which is very compact, made of prisms of hydroxyapatite, there is no innervation, there is no tubules, and the gum gingival coverage of all the cementum and the roots, you have a healthy tooth, you don't have all the area which is prone to dentine hypersensitivity is covered. Once you start having exposure of dentine because of gingival recession in the second, as we could see here, once you have a gingival recession here, probably because of abrasive and erosion forces, you could see that this dentinal tubules, this is a electron microscopy, a view of an exposed dentine. And you could see here, this is the dentinal tubules. Now, you would be amazed to find out that in each millimeter, you have 57,000 dentinal tubules in each square millimeter in the coronal part, and 56,000 dentinal tubules in the coronal part, or the apical part. And as you see here, the dentinal tubules, once you have the dentinal tubules exposed, there is what we call the SMED layer, which is the covering layer, the bio layer, which cover and block the dentinal tubules, will be removed immediately, and you will end up with an open tubules. Can we see in this electron microscopy image? See dentinal tubules with an open orifices, and this is why we're having an open tubules, main cause of dentine hypersensitivity. Why? Well, the dentinal tubules, it extend from the exposed dentine, reach until the pulpal area, until the pulp, where there is what we call the odontoblast complex. If you remember from our dental anatomy classes, the the pulpal floor, you have the odontoblast, and within the odontoblast, there is the innervation system. And within the dentinal tubules, you have a fluid. And of course, this is one of the theories. There are three theories to explain dentine hypersensitivity, but the most accepted one is the Brandstone theory of 1973. He introduced this beautiful, which is well accepted by all the academic, that the dentinal tubules has got a fluid, and this fluid will move inward and outward. Now, the fluid travel once it's any stimulus, thermal, tactile, osmotic, or mechanical, this fluid will stimulate the nerve ending around the complex of odontoblast, and there's a nerve impulse to the pain center in the brain, which can cause this short, sharp pain. So the excited nerve reaches the brain and cause this short, sharp pain. And the osmotic pressure will suck the fluid in, and again will also cause the stimulation of the nerve to cause this sharp pain. So any open dentinal tubules will cause movement in the fluid, which can stimulate this short, sharp pain. It's very important to understand the pathophysiology because that's related to the management also. Now, it is very important. We in the Arab world, unfortunately, 97% of our children, they suffer from dental caries. 40 to 60% of our adults, they have some kind of periodontal and periodontal breakdown and ligament breakdown and some kind of chronic periodontitis. The incidence and the prevalence of parafunctional habit is very high. So it's very important to learn that in order to reach to the diagnosis of dentine hypersensitivity, you have to exclude all the not well-known dental and facial pathology, like sinus pain. As we know, when you have maxillary sinusitis, you will have pain in the premolar and sometimes in the molar, depending on the size of your sinus. If you have a joint pain, either temporomandibular dysfunction syndrome or in the neck, also this you have radiating pain into the mouth and also could mimic the sharp pain, which can cause also this problem. And also, as I said, 97% of our children have some kind of dental caries. And so dental pain could arise either from dental caries, and like pulpitis can give you throbbing pain and infection, and also you could have dental hypersensitivity, of course. Cracked tooth syndrome also can give a rise to pain. Also, severe bruxism. A lot of patients which I saw in the last 2 years after COVID with the stress, because of the stress of the COVID and the other circumstances, they grind their teeth, so it will be very painful because of the mechanical trauma. And also don't forget that there is a soft tissue pain like aphthous ulcer or any kind of ulcer of any irritation, whether mechanical, chemical, or physical, to the soft tissue or to the gingiva or to the mucosa, can also cause this kind of pain. So you have to exclude all other causes of pain before reaching to the diagnosis. And please, it's very important that we educate our patient that they cannot diagnose themselves by dentine sensitivity or having sensitive teeth and go and just buy toothpaste and thinking this will solve the problem. They have to come to the dentist to establish the right diagnosis. Now, this is a beautiful table discussing what is the pain which is not dentine hypersensitivity. As I mentioned, now cracked tooth syndrome is very sharp, intermittent. This is the sort of presenting feature, and it's provoked by biting or chewing, and it's always associated with, as I said, bruxism, parafunctional habit, or trauma to that tooth. pulpitis, inflammation of the pulp, whether reversible or irreversible. It is sharp, stimulating, evoked, throbbing sometime, and could be stimulated and started by either thermal or acidic or osmotic stimulus. And the main causes for associated feature is either there's a big carious lesion which reach to the pulp, or you have a big restoration can reach to the, and some chemicals reach to the pulp and cause this pulpitis. Also periapical periodontitis, where you have a deep continuous pain and always aggravated by biting and chewing, and associated with deep pockets, more than 6 to 7 millimeter, redness and swelling. Also, pericoronitis, inflammation of the pericoronal tissue around wisdom tooth. It's a sharp stabbing and stimulation evoked by either thermal, acidic, osmotic, or tactile, like brushing or chewing, and associated feature with cavity preparation or restoration. By fever, associated with high temperature, and you could see the imprint sometime of the upper wisdom tooth or the upper 7 on the pericoronal tissue. And the last kind of pain, which is not dentine hypersensitivity, is like post-operative sensitivity. Sensitivity that we dentists create. It could be sharp stabbing and evoked by, as I said, by either thermal or acidic, like Coca-Cola, osmotic, or by tactile. And it's either like cavity preparation, crown preparation, veneer preparation, or even doing whitening or doing bleaching, whether home bleaching or an office bleaching. If you use a very high carbamide peroxide or hydrogen peroxide, can cause this kind of. So it's very important to exclude other causes before reaching to the diagnosis of dentine hypersensitivity. Now we know the etiology, we understand the pathology and physiology. Let's discuss the treatment strategy. Well, as I mentioned before, the theory, the hydrodynamic theory of Sterman, that the fluid which moves between the dentinal tubule orifices and the exposed dentine, which reach to the pulpal complex of odontoblast and the nerve, this can trigger pain. Now, the smear layer, our objective in order to stop this condition, in order to treat the dentine hypersensitivity, either to reform the smear layer to occlude the dentinal tubules, or stimulate the formation of intratubular dentine around the inside the tubules, or induce the formation of tertiary dentine. So it will be a barrier between the dentinal tubules and the odontoblast nerve complex at the pulpal end. The second strategy important is to nerve desensitization, using some chemicals to numb and depolarize the nerve end at the pulpal area. And this decreases the interdental nerve excitability. Once the movement of the fluid will reduce the excitability of the nerve and manage and control the triggering the pain from this area. Now, the layer formation and tubular occlusion. How can we occlude these dentinal tubules? Well, the occlusion helps to prevent the nerve from being stimulated by reducing fluid movement within the dentinal tubules, as I mentioned before. So, is there any way we could find a material that could create a blockage to this opening, as we could see here from electron microscopy? You see the opening here, and you see here the beginning of how to occlude. This is like the dentinal tubule being occluded by some kind of technique, which we're going to find out very shortly. Now, one of the treatment strategy which we use in combating this condition is potassium nitrate, or potassium component as a whole. Potassium nitrate, it's very important element that is used to depolarize the nerve ending, if you like, to numb the nerve ending. So even if there is a fluid movement, this movement will not trigger any impulse to go to end up as a sharp, short pain. Potassium nitrate, as I said, will depolarize the nerve ending and stop the nerve excitability. And it has been used for many years now. The potassium ions in toothpaste depolarize the nerve and inhibit firing of impulses to the brain. Thereby, so it's preventing this dentine hypersensitivity, short, sharp pain. And in order, now we understood, so the treatment targets, as I'm to summarize, or our strategy in the treatment could be either we occlude, block the dentinal tubules, so will not cause the fluid to move either in or out. Or the second strategy is to numb or depolarize the nerve ending, so this nerve ending will not send an impulse to the pain center in the brain and causes the dentine hypersensitivity. Now I would like to talk about GSK research. Now GSK, it's an innovative company which started all the research in dentine hypersensitivity. Their strategy in the toothpaste development, many years ago they started, is by exploring study and how the ingredients work with using breakthrough technology. For example, the efficiency of occlusion for novel technology. How can we find a novel technology that will occlude the dentinal tubules? Also, GSK was very fast healthcare provider to start by pioneering the in vitro and in situ studies. In vitro in Latin mean outside, so we do like you use a tooth extracted and do all your research. In situ is to use it inside the mouth and do the study. So this is a clinical relevant product feature. It's like using a toothpaste characterization, what kind of property and how the robustness of the ingredient use to combat the. And also GSK started the clinical trials. I was honored to work with Dr. Zakaruska at the Eastman Dental Institute, as I mentioned before. And Dr. Zakaruska was professor actually, she's a professor of oral medicine. And she was a member of the European study for non-carious lesion group study. This is a group which is a pan-European group. Dr. Zak, member representing the UK, one of 10 professors from the different UK university, member in this group, which is set up by the GSK to study different aspects of dentine hypersensitivity and how to manage it and the prevalence and different research. They published probably more than 3,000 so far research. And also they've done a lot of clinical trials to confirm the efficacy, prevalence, and the impact on the patient quality of life. And the dentine hypersensitivity questionnaire. This is also a group started by Dr. Biolia from Exeter, professor actually, in 1993, started this questionnaire to discuss the impact of dentine hypersensitivity on the quality of patients, on the quality of life for patients who suffer from. And there's so many, also they published so many articles from this DHEQ questionnaire, which uses also some kind of psychometric analysis to quantify and qualify the effect of dentine hypersensitivity on patients' quality of life. Now, one of the innovative, actually, technique and strategy which GSK used is the introduction of Novamine. Now, Novamine, it's a calcium sodium phosphosilicate. It's a bioglass system. And this calcium phosphosilicate, once you apply it into the mouth, on the teeth, on the exposed dentine, once it can become a sort of fused with saliva, there will be an ionic exchange. So the sodium will go out from the Novamine, from this calcium sodium phosphosilicate, and you will get the sodium will leave this bioglass, and the hydrogen from saliva will enter to produce some kind of like hydroxyapatite. And as we know, hydroxyapatite is the crystals, is the main component of dentine and enamel and all the bone all over human body and enamel. So hydroxyapatite crystal is the main component of dentine. So the Biomine concept, once you apply it, and it will last for 12 hours. So if you apply Biomine using a toothpaste with Biomine, the sodium in this bioglass will exchange, will have some ionic exchange, will leave the Biomine, and hydrogen will come from the saliva to create like hydroxyapatite crystals. And this hydroxyapatite crystal will block the dentinal tubules beautifully and reduce the sensitivity from and the pain sensation of dentine hypersensitivity. Now, this is some of the study conducted. This is energy dispersive X-ray, EDX. This is electron microscopy radiological assessment to assess metal and components and see. They use it in industry, we use it in medicine, it's been used widely and even military to find out the component and the similarity between two metals, between two materials. And in this study, they compare the hydroxyapatite produced by Biomine to the natural dentine surface. And as if we see here, that it's exactly the same condense, the same structural like. So this will give you an idea that the hydroxyapatite-like substance, which is formulated from the reaction of Biomine with saliva, it's very similar in hardness and in resistance to acid and to bacterial attack like the hydroxyapatite. And if we, this is also a beautiful study done by L in 2011. They study that the main percentage changes in the hardness following 4 days of twice daily brushing. That we use Novamine, dentine, arginine toothpaste, and fluoride varnish. So using 4 different groups. This is a clinical trial where we use a toothpaste every 12 hours, twice a day, 5% of Novamine toothpaste, and we could see here that the hardness, it's even much more higher than the normal dentine by 50%. So the Biomine producing hydroxyapatite after interaction with saliva is much harder than the dentine itself, or even using 8% arginine toothpaste, or even using fluoride varnish. So Novamine has proven by clinical trials and by all the research that it can build hydroxyapatite-like layer on dentine and very resistant. Now, this is also some beautiful electron microscopy study. This is, as we could see here, this is the acid-resistant layer up over to 5 days. So we're exposing exposed dentine to bioamine for 5 days. And then we study it by electron microscopy. And this is like magnified by 8,000 times. This is before we start using the bioamine toothbrush. This is after the first day, and you could see here how the opening, the orifices of all the dentinal tubules, after even 1 day, start occluding, and after 5 days, it's completely blocked. So hydroxyapatite-like crystals will be formed after 5 days and block these dentinal tubules. The other study, also 2011, this is the testing of robustness of hydroxyapatite layer. This is before brushing. This is after brushing. So you see this is an open dentinal tubules, occluded, and then they apply acid. They apply acid, which is the cola, any soft drink, which has got 2.5 pH, which is very acidic, like vinegar. Still, the bioamine producing hydroxyapatite still intact, hasn't opened any tubules, and this shows how effective is the bioamine technology in managing dentine hypersensitivity. This is also this is studying. Now we are studying clinically. This is going to clinical trial. The studying by VAS. Now VAS is the visual analog scale. This is a psychometric scale. As you know, in order to, in research, in academic research, in medical research, you have to have a quantifiable. Everything has to be scaled by figures and numbers in order to compare things. So some of the psychiatrists in the last century, they developed this visual analog scale. It's a scale of from 1 to 100. They measure the intensity of pain. They asking the patient, how is the pain? And that is from 0, no pain, till 100, terrible pain. And patient will mark from this, and then you measure it by millimeters, and you extract from 1 to 10 the manifestation or how patient feel. This is a psychometric scale. And when you say placebo, this is a double-blinded clinical trial. Placebo is using a normal toothpaste with no bioamine, and the green bar here, this is a Novamine toothpaste, 5% containing, and as we see here, this is the score of pain. The patient would say, is it no pain or it's terrible, 10. The placebo, which there's no Novamine, this 4, painful. With air, when you use air displacement, it's like half. There's 2, while it's nearly 4 into the placebo. In the cold and the thermal stimuli, again, it's more than 4 in the placebo, which is they don't use any desensitizing like the Novamine. While the Novamine containing toothpaste, it's really half of the patient is feeling half of the intensity of pain. And this, of course, a very accurate clinical trial, and it shows clearly that Novamine does work in managing the dentine hypersensitivity. Now, the other armament which GSK has introduced to dentistry is the use of Stenos Fluoride. Well, Stenos Fluoride, or the 10 fluoride, it's built a layer around the dentine, which occlude the tubules and help reduce, and also because Stenos fluoride, as we know from our pathology, oral microbiology, Stenos fluoride is bacteriostatic and bactericidal. So it will inhibit the growth of pathogens like Streptococcus mutans and all the other microorganisms which causes periodontitis or dental caries, and also kill them. It's bactericidal. So Stenos fluoride, it's built a layer of dentine, can occlude the dentinal tubules, and also because of its bactericidal and bacteriostatic property can kill and stop the growth. So reduce the plaque formation and also reduce gingivitis, which is the main cause of the periodontal breakdown and gingival recession. Again, this is another innovation in compacting. Now, again, this is another clinical trial, 2013, using Stenos fluoride to see is the Stenos fluoride resistance to the acid challenge. As I said, Stenos fluoride could produce both a dentine, can occlude the dentinal tubules, and also will help producing intratubular dentine. And this is what they call it, the COLA challenge. This is this clinical trial. This is in vitro study where they use 0.7% sodium monofluorophosphate. This is standard, been used in toothpaste for probably the last 200 years. And while using 0.4 Stenos fluoride. So we compare two kind of toothpaste, the sodium monofluorophosphate, which is the standard toothpaste, and the 0.4 Stenos fluoride. If we could see here, using the standard monofluorophosphate, it's after, you see, immediately after applying the COLA, you could see the opening of dentinal tube. This is closed. Once you apply the acid, once the acid is stimulated by soft drink, you could see how the dentinal tubules open. And I said to you before, it's amazing to find out that there's 57,000 dentinal tubule in square millimeter. So it's all opened up. While if you use the toothpaste containing Stenos fluoride, we could see here the same amount of COLA, the same amount of acidic stimulus exposed to this dentine, and you see still all the dentinal tubules still occluded, and it's even more occluded than before applying Stenos fluoride. And as we can compare these two electron microscopy images. Stenos fluoride toothpaste, also going back to the psychometric scale, the visual analog scale. This is the scale which measures how much the patient is feeling of the dentine hypersensitivity. And we could see here also, this is a clinical trial, double-blind clinical trial, using, again, the normal fluoride toothpaste, the standard fluoride toothpaste, and using Stenos fluoride toothpaste. And as we could see here, that when you start the baseline, when you start both before applying the fluoride toothpaste, they both suffer from score 6 of the visual analog, which is painful. And after 4 weeks, the normal monofluoride is still like 5.5, while after 4 weeks, Stenos fluoride, it's reached to 3.5. After 8 weeks, the normal regular fluoride still on a very high, very painful, 5, while 8 weeks later, it's 2.5, which is very minimum discomfort. And this is a success. This proves that the use of Stenos fluoride in toothpaste do control and manage dentine hypersensitivity very well. Now, going to potassium nitrate. again, potassium nitrate is one of the one of the management strategy used by GSK many years ago. And as I mentioned before, potassium nitrate and potassium containing formulation, it's used in the Sensodyne, like toothpaste, potassium formulation. It is very important to control dentine hypersensitivity by, as I said, they reduce relief of pain because of the block the sensation, the nerve sensation. So this is another clinical trial where they use sodium chloride and sodium, as we could see here. Sorry, potassium. We use potassium formulation, potassium chloride, 3.7%, 32 patients used in this clinical trial, and using 5% of potassium nitrate. And we could see here that the reduction in pain sensation, as we could see here, this is starting with 5, very painful, after using it for 2 weeks, 4 weeks. When you get to 8 weeks, it reached to very minimum discomfort, while the placebo, the control group, the group which they haven't used any potassium formulation, they still very painful within the level of 3. So the amount of reduction proved that potassium formulation, whether potassium chloride or potassium nitrate, can be used effectively to control dentine hypersensitivity. The desensitization technology of the potassium nitrate, as I mentioned, the beauty of potassium nitrate and potassium chloride, they numb the nerve. As I go back, so dentinal tubules, open dentinal tubules, fluid movement, either inward or outward by osmotic, can stimulate or can sensitize the nerve complex at the odontoblast level at the pulpal area, and this causes the induction of pain and impulse and cause sharp, short pain. Now, toothpaste that contain the potassium nitrate, 5%, can block and can depolarize this nerve, so it will not send any impulse. So also again, controlling on managing dentine hypersensitivity. Again, we're using so always as a dentist, once we diagnose this patient having dentine hypersensitivity, our first line of managing is to use toothpaste containing one of the technology I mentioned, either the potassium formulation, potassium nitrate 5%, Novamine technology, or the Stenos Fluoride, 0.4% Stenos Fluoride. These three technology can control the dentine hypersensitivity beautifully, and now we give the patient at least 8 weeks by using these toothpaste. And if a patient come back to me and say, "Doctor, I'm sorry, I'm still having pain," we have to go for further way of managing, like nowadays laser being used beautifully to control, because the laser, especially the diode laser, can occlude also these dentinal tubules if the toothpaste usage of toothpaste for 8 weeks failed to control the dentine hypersensitivity. And also very important, before also giving your patient the instruction to use one of these three technology, the Novamine, potassium formulation, or Stenos Fluoride, it's very important to diagnose the reason why this patient have the dentine hypersensitivity. If it is because of vigorous or very hard way of brushing, we have to modify it. If it is because of the excessive use of acidic food and drink, you have to give dietary advice to control it. And because, or if he has a paroxysm, And this paroxysm can cause also removal, abstraction and removal of enamel, exposing dentine. You have to give your patient some kind of splint to control. So control the cause before treating. This is very important. Otherwise, toothpaste will do nothing, because if the patient will continue losing enamel and continue exposing dentine, well, you're not doing any good for the patient. You have to establish the causative agent, control it, manage it, and then start with your therapeutic 8 weeks of toothpaste containing one of these 3 components. And if he come back to you with a severe pain, you have to reassess the situation and either use for some of the, like one of these dentine bonding agent, glass enamel cement, composite restoration, some gluma, or as I said recently, I've been using laser beautifully to control dentine hypersensitivity. Now, this is one of the study by the group which I mentioned, the DHEQ, which is the Dentine Hypersensitivity questionnaire group, where they ask, I think it was 7,000 or more than, about their experience with dentine hypersensitivity. And from this sample, 25% reported that they have sensitivity several times a day, which means a quarter of the sample. And the other 38% of the sample studies reported sensitivity several times a week. And sorry, yeah. Now, what are the impact on patient? As I said, GSK was innovating in setting up some of the main one of the highest research group in Europe regarding the dentine hypersensitivity. One of the clinical trials conducted by the European group of non-carious lesion, this is which I mentioned before. They studied 3,000 patients between the age of 18 to 35-year-old over seven countries in Western Europe, testing pain response to stimulus using the VAS, the visual analog scale, and giving them the patient questionnaire. Now, the finding was the global prevalence, according to this study, is 1 in 3. So in each 3 patients coming to your practice, 1 of them will have dentine hypersensitivity. The finding that 42%, nearly half of the sample studied, 3,000 patients, having some kind of dentine hypersensitivity, while 28% reported that the sensation was very important or important to them. So this, which means the impact on the quality of life on these 28% is very high. It's sometimes really, it's terrible to have this sensation. Now, 52% of patients with dentine hypersensitivity, they fail to report to their dentist, whether because of dental phobia, whether because of the high cost of dentistry in Western Europe, I don't know. But half of the patient, nearly more than half of the patient, fail to go to the dentist to seek advice. And I'm sure some of them will probably have another pathology because of their avoidance of routine dental checkup. Now, the main finding of the study of this ESR, the European group, the restrictions imposed by this condition, the hypersensitivity, dentine hypersensitivity, it reduces the pleasure of eating and drinking. And as we know, food and drink, it's one of the main pleasure in life. If you're restricted, well, you're affecting patient quality of life. A lot of patients reported that they cannot eat ice cream. Probably it's good for reducing caries because each cone of ice cream has got 20 spoons of sugar, but Some people, they love ice cream. So you are really stopping them from joy of life for them is to have ice cream. They have to do some kind of adaptation. This study showed that, the patient with dentine hypersensitivity, they have to adapt. So avoid cold and food and drink, avoid using certain teeth while eating. And this adaptive behavior will annoying to the patient. Also has emotional impact. This annoyment, doing something that causes pain, sensation of irritating, annoyment, stress, and patient gradually will be depressed because of this condition, because of the emotional impact of dentine hypersensitivity. Also, the social impact is huge. So a patient with dentine hypersensitivity will be very anxious in eating and drinking outside his home or outside his surrounding, because he's worried that if he eats and he has developed this sharp, short pain will affect him badly. And of course, also the effect of identity. Patient who feel pain while eating, he will give him the feeling of he's getting old, and this is also another negative effect on the quality of life of your patient. So this is a very important study by this European group, which I wanted to show you the result. So let's sum up our finding, and let's sum up this evening by, first of all, we all agreed that dentine hypersensitivity is a short, sharp pain arising from exposed dentine in response to stimuli that cannot be classified as any other form of dental pathology or defect. We have to make a differential diagnosis before we reach to the conclusion of dentine hypersensitivity. So we diagnose by exclusion, as we call it. So you exclude all the other defects and pathology before you diagnose your patient with dentine hypersensitivity. You have to, as I said, very important, you have to control the etiology and the factors that causes the dentine hypersensitivity before going to the treatment. The leading cause of tooth wear, as I said, it's either gingival recession, exposing dentine, or tooth wear. Exposed open dentinal tubule allow fluid to move in or out, which excite the nerve ending in the odontoplastic area, which causes pain. Forming a layer over or intra or within dentinal tubules decrease the intradental nerve excitability, so reduce the sharp, short pain. We have the Novamine technology, which I mentioned, which builds a hydroxyapatite layer, which occlude dentine beautifully. Stenos Fluoride build a layer, occlude tubules, and also help control plaque because of the bacteriostatic and bactericidal property of Stenos Fluoride. Potassium ion will depolarize and numb the nerve ending, so you don't have this excitement of nerve. So no impulse, pain impulse to the brain center. Sensodyne toothpaste work with recommended twice daily brushing. As I said, all the technology, the effect of potassium nitrate or bioamine or Stenos Fluoride, their action duration is only 12 hours. That's why we always advise our patient to brush their teeth 2 minutes twice a day, every 12 hours. So according to the European group, they found that 1 in 3 patients, they have dentine hypersensitivity. However, I think in the Arab world, it's much higher, not like Europe, because of the prevalence of bruxism and parafunctional habit, and because of we use a lot of, unfortunately, acidic ingredients in our diet, and also the excessive use of soft drinks and fizzy drinks, unfortunately, which cause the erosion. So hypersensitivity, to conclude, it affects the quality of patient daily life, as the study of European group has beautifully mentioned. Well, thank you very much for listening this evening. And I will be delighted if anyone has any questions. I'll be delighted to answer. And thank you very much for your listening. Thank you.
I'm not sure Dr. Osama can hear us. I would like to take over. Thank you, Dr. Hamid, for your actually fruitful and really amazing session. I have seen actually the report. There are more than 850 participants actually in this session, which is really, really amazing, and have actually seen like many questions. So because actually of the time, so we cannot actually go through them all. However, you can shoot, everyone can shoot his questions. We actually pick up like a couple of questions right now. So we'll take this opportunity with you, Dr. Hamid, and to answer those doctors who are actually asking in the chat. So the first question actually started with like, is electrical toothbrush is recommended like in the dentine hypersensitivity cases?
Well, according to the latest study in 2020 by the School of Hygiene at the Eastman Dental Institute, they did a clinical trial where they studied two control group, one using manual toothbrush and one using electrical toothbrush. And the result of the study showed clearly that electrical toothbrush are more useful and more effective in removing dental plaque and also reducing the amount of abrasiveness on the, because it is electrical, it will less damaging, it will less removing the enamel and causes exposure of dentine. So yes, electrical toothbrush has much higher privilege and higher advantage than the manual, not only in combating dentine hypersensitivity, but also in maintaining a good oral health. So always advise your patient to use a electrical toothbrush.
Good. So the other questions actually coming from Dr. Ahmed. He was mentioning, what is the prevalence of dentine hypersensitivity in dental practice?
As I mentioned, I did like clinical observation. I found that in the year 2020, 60% of my patients I saw during this year, they have some kind of dentine hypersensitivity. And this is only in Riyadh practice, not in London. It was only because in 2020 I was mainly in Riyadh, didn't come to London because of COVID.
Yeah. So the other question actually coming from Dr. Muhammad, he was mentioning what are the barriers in diagnosing dentine hypersensitivity?
Well, there is no barriers, but it's very important. As I mentioned, I always say that we shouldn't really allow the notion that patient could go and buy toothpaste from the market without proper diagnosis by a dentist. So the idea is, please, for everyone who's listening, that we have to make this awareness to all our patients that do not make your own diagnosis as far as dentine hypersensitivity. You have to come to me as a dentist. I will do all the proper assessment. I will rule out, as I mentioned in the presentation, all the other causative factor, all the other pathology, pulpitis, cracked tooth syndrome, soft tissue ulcer, aphthous ulcer, temporomandibular joint dysfunction syndrome, pericoronitis, maxillary sinusitis. Once I establish, no, I could see exposed dentine, there is no other pathology, so this is the right diagnosis. The barrier for the diagnosis, if we do not exclude other pathology, we just go ahead and mention to the patient, well, it's sensitive, go and use Sensodyne toothpaste. No, you have to do proper assessment, control the causative factor, modify patient diet, modify patient behavior as far as the oral hygiene practice, advise them to use electrical toothbrush if they use vigorous force more than 32 grams, and this should remove all the barriers as far as the controlling and the diagnosis and management of dentine hypersensitivity.
Very nice, very nice. So Dr. Muhammad Sheikh is asking how to differentiate between periapical periodontitis and deep periodontal abscess.
Well, periapical periodontitis and deep periodontal abscess, well, there is really no, I mean, it depends. If you have a periapical abscess, you will have an abscess, if it is an active abscess, not a chronic. You will have association of swelling, you have association of redness, you will have some kind of temperature, increased temperature, and you could see the swelling there. While the deep periodontitis, it's a chronic condition. You could only diagnose it by X-ray, by classifying the periodontal according to the new European periodontal classification of 2017, by using X-ray and by probing depth.
Yeah. So now, one last question that we can take because of the time. So
Sure.
Can laser be used in the treatment of dentine hypersensitivity?
Yes, as I mentioned, I've been using laser, but we only use because of it's an advanced stage. So first of all, we have to try and advise our patient to use one of these 3 component toothpaste for 8 weeks. If after 8 weeks, patient came back to me and say, "Doctor, I'm sorry, I still have the same sensitivity, it hasn't gone," I could go for other more advanced restorative, including laser or dentine bonding agent or glass enamel cement, or even using composite. Yes, laser is very effective, but it has to be the second stage of managing dentine hypersensitivity.
Yeah. Thank you, Dr. Hamid.
Thank you for inviting me.
And thanks for all participants. Before we close off, I would like to actually highlight a couple of things. As you can see from the dashboard, you can download your certificates, and also there is a couple of links that token. The first one is about JADA, Journal American Dental Association. This is actually free access. So once you are registered in the portal, so as a dentist, and you will have an ability to read through this magazine. It's a well-reputed magazine. And another one is a request sample. So once you are an access to the portal, you will be having ability to request a sample, and then will be delivered to your doorstep. So and also don't forget to fill up the survey. And until then, so we will see you again, and thank you for your participation. Thanks, Dr.
Thank you, Basim. Thank you very much.